Guys, we're actually, in the sake of time, we're going to go ahead and have the panel come up to the front. Sorry to cut you off on those questions, but if you do have a question for Dr. Ellis, we can start with that with our panel. But if we could have everybody from the panel just have a seat up in the front in those 4 chairs, and we'll go through a quick Q&A session and kind of generate some discussion on some of these. First, is there any questions for Dr. Ellis in regards to the pelvis and the hip avulsion injuries? Yes, sir.
I deserve a few.
All right, our first question here.
Yeah, how, because I've seen a couple avulsion fractures at the hip, so what are some of the key differentiating diagnosis for that compared to apophysitis?
Yeah, I think that's a great question. Number one, I don't, to date, I do not believe that having apophysitis puts you at risk of having an avulsion fracture. I think that's still unclear. Number two is it's all in the history. I think apophysitis is an inflammatory condition with an insidious onset, kind of slowly comes, happens with activity, gets better when you don't do activity. I think an apophyseal fracture is usually I landed, I heard or felt a pop, or I had sudden pain, and now I have pain all the time. And so that's how I would distinguish two of them. And I do think they're dramatically different practices because the avulsions I will remove from activity and treat it almost as if it is a fracture.
Other questions in our audience here? Okay, we'll go to another one online then. Seems like all of you mentioned anti-inflammatories as a potential part of a treatment protocol. How do you guys walk the families through implementing the anti-inflammatories, and how long do you recommend that they're on them?
Anti-inflammatories as needed. If they are, actively symptomatic, then I think, doing a 7 to 10 day course of anti-inflammatories is reasonable. But if they are not having pain, or the pain only comes after activity, then just as needed. Yeah, and always encourage them to take it with food if they are taking anti-inflammatories, not to irritate their stomach.
I may just comment on that briefly, but I really, I think everything depends on the athlete and what the goals are. So, sometimes I may change my anti-inflammatory recommendation based on, what we're trying to achieve. Do we have a tournament in 4 weeks? Do we have, because these are inflammatory conditions, so you're not only treating the pain, but you're treating the process of how the condition occurs. So I don't hesitate to implement, particularly for an apophysitis around the pelvis, a 14-day course, and I like to use naproxen. It's easy. It's in the morning, it's in the afternoon, and we know it's well tolerated in children because the rheumatologists use this very, very frequently for very severe inflammatory conditions. So I like naproxen. I think it works very well. I don't hesitate to schedule a 14-day course, but I would say that I would tailor my recommendation based on what the goals are and trying to figure it out. If you can take a rest for 3 months, well, that's ideal, right? But if we're in a scenario where we have something that is important to the athlete, the parents, in which we want to try to modify our treatment to achieve a goal, well, I think that's what we do. We would individualize some of those cares based on the athlete and what the goals are at the same time, is trying to treat the overuse condition.
All right, we have one more question. Go ahead.
Really quick, yeah. So I noticed a lot of static stretching in your programs, but do you guys ever defer to an active type dynamic warm-up before actual activity?
When at all possible, I refer them to our excellent physical therapists for guidance.
No, I think that's really, so, yeah, I mean, I think I completely agree with your point, because I think we know now that dynamic stretching is really a valuable tool. The reality is it is a challenge sometimes to educate dynamic stretching, because that is something that can be overused so quickly, right? And so you can't, it's really easy or perhaps clinically easy to instruct static stretching, and that may be an easy solution to a common problem. But if we had resources available enough to actually make sure that these kids do proper dynamic stretching, I think we'd be more likely to do it on a routine basis. I'm always fearful to say, go do this dynamic stretching, because I don't think they know how to do it. They're going to end up pulling something if they don't do it correctly. So it adds a bit of complexity to go through the dynamic stretching. I think if you have a resilient course of apophysitis or a high-level athlete, utilizing all of our physical therapists around the community's resources to help us instruct them would be what I would do in terms of my practice. But for maybe some of your recreational athletes that just need a simple solution to a common problem, I think static stretching oftentimes will take care of the problem.
I lied, one more question. Recreational athletes, do you have some of those? We don't tend to see those very often anymore.
Do you see a difference or as far as recovery time versus or apophyseal problems in weight-bearing versus non-weight-bearing body parts? So like upper extremity versus lower extremity, does that take longer time, or is it about, it's just depends on the person, depends on the cycle?
Well, I think, lower extremity, both Osgood's and Severs can be really recalcitrant. They can take a long time, and I think it is, part of that weight-bearing or repetitive impact cycle. I mean, certainly with the upper extremity, you have more opportunity, whether they afford themselves the opportunity, but you at least have the opportunity to remove that, area from the repetitive stress. So, I think that those two are different. The pelvis, probably can be rested, from running and jumping and twisting things a little bit more than just the daily, walking or stairs that can sometimes flare up severs and the tibiotubercle. Yeah, sometimes families will struggle for 12 to 18 months with either calcaneal or tibiotubercle apophysitis. That can be common.
Any other questions? Okay, well, we really appreciate you guys coming out. We'd love for you to join us next month with Ray, who's going to cover pediatric and adolescent ankle injuries. Thanks again. Y'all have a great day.